All right, so in the chat, if you guys can tell us your name, your pronouns, if you feel safe to share, where do you practice or work? And then do you need NASW, VA, CEs, or MBCC? And then what do you hope to learn in this training? Put the information in the chat as well so that you guys can on this. Pronoun.
Sultana, do you want us to put that in the chat or just go around and?
Put it in the chat.
Okay.
I'm also putting it in the chat as well. So if anybody else comes on, they'll see it. Don't spend too much time here. All right, so I put it all in the chat of the information to share. So let me just do my introduction. Go to the next slide. Hi, everybody. So my name is Sultana Karim. I am the Deputy Director at Postpartum Support Virginia. I'm also a psychotherapist and owner of Karim Counseling Services, PLLC. A little bit about my background. I have a Bachelor of Science degree in psychology and a Master of Arts degree in counseling psychology. I am duly licensed in both the state of Maryland and Virginia. I am also a certified trauma professional. I have over 10 years of experience working with children, adolescents, adults, families in various settings. So outpatient mental health, domestic violence shelters, children advocacy centers, and hospital setting. I'm also, sorry, I just looked at my note. No, I am a PMAD survivor. So I struggled with postpartum PTSD after the birth of my daughter, since I had a traumatic birth experience. Next slide. So let's start by first knowing who is PSVA, what's the mission for PSVA or Postpartum Support Virginia. So our mission is to educate families, healthcare providers, and communities about perinatal mood and anxiety disorders, provide resources to help perinatal people and their families overcome anxiety, depression, and other PMADs. Next slide. So we fulfill our mission by providing direct resources to perinatal people through our social support services, which includes our warm line, our support groups, as well as our peer mentor program. And these are all free and accessible to perinatal people. We educate healthcare providers, maternal health providers, as well as mental health professionals on the spectrum of PMADs, how to screen for them, as well as specific trainings for mental health providers on therapeutic approaches to treating PMADs. We also have training for nurses on how to identify PMADs when they're looking at a chart and interacting with the perinatal person. Act as a resource for information as well as referrals to train mental health professionals. We gather communities to create community level solutions for PMADs. So we do this by having our coalitions. We have a perinatal mental health coalitions throughout the state of Virginia, and we meet quarterly to discuss not only what is the new topics or new things that are happening in the perinatal field, but also what things that we can do in the community to help those who need resources or access to care. We also conduct community outreach and education to raise awareness and expand our referral resources for PMADs. So you can support our work. So as you know, the PSVA is a nonprofit organization that relies solely on the support of volunteers, generous donors, and partnership with foundations, businesses, and community organizations to sustain our work. You can help our mission by volunteering. There's a lot of different roles that you can volunteer as, such as like communication, grant writing, fundraising, event planning, any of our social support services, whether it be the Warm Line, support group, or our peer mentor program. You can also donate. You could be a one-time contributor or become a hope and help sustainer through our monthly giving program. Another way you can help is help us make connections with others in the community. So if your employer or religious organization want to donate to a nonprofit, or if you want education on PMADs at your place of employment or religious organization, or really anything, any aspects, just reach out to us and we can try to get connected. Next slide. So this presentation today will have 3 objectives. The first is to identify and assess for perinatal mood and anxiety disorders, also known as PMADs. Utilize screening tools to assess for PMADs, and then discuss resources available for perinatal people and families. And the resources that we'll discuss, will be services that we offer at PSVA and some external services that you can also link clients to if they need that support. Okay, next slide. I do want to note that there is a limitation in research. So through this presentation, PSVA refers to the most up-to-date research available, but we have to highlight the limitations to the research in our field. It tends to be very heteronormative. It's centering around heterosexual people. So essentially it's not inclusive for those who identify as anything other but mom and dad, or women and man. It is centered whiteness. So research has often left out community of color in their research. However, in the past 3 years, there has been an overwhelming commitment amongst research to address white-facing research, specifically as it pertains to maternal deaths, death rates for Black and African-American birthing people. And oftentimes, so in the past 3 years, you also hear the term BIPOC, which refers to Black, Brown, Indigenous, and people of color in research as well. Next slide. So let's talk about Virginia stats and where do we stand as a state. Each year in Virginia, 100,391 babies are born. 9,500 are born prematurely. 280,000 perinatal people live in a maternity care desert, was essentially meaning that they don't have access to resources that they need. 24,500 people will suffer or struggle with a PMAD or multiple PMADs. The cost of untreated PMADs over 5 years is $31,800 per mother-infant dyad. Maternal mortality rate is 16 in 100,000 births, live births. So keep this in mind as we kind of go through our slides and talk about perinatal mood and anxiety disorder and what the symptomology is and the risk factors that play a role. Next slide. So before we kind of dive in, what are some myths that you all have about motherhood, parenthood, or just ideas that you think of when we talk about this time frame? And you can either put it in the chat or unmute yourself, whichever you're comfortable doing. coming in. A mother is supposed to be blissfully happy. Yep. It is magical and will connect and love your baby instantly. Yep. Any other thoughts about parenthood, motherhood? You will have plenty of support. What about the strong mother? Like, you have to be strong and be able to do everything. Yes, learn to multitasking. It should come naturally. Yes, that's definitely a misconception. Yep. You could do it all on your own because women have been giving birth to babies for hundreds of years. Yep. Oh, it's coming in faster. You should just naturally know how to be a great mom. Yep. That one. Mom should take the primary role. Tell me more about that, Jessica. What do you mean? I know what you mean, but let's elaborate on what you mean by that. Take care of baby and children. Yep. Even the household, right? Or balancing, having the balanced act of taking care of the children, working, taking care of the house. Where is there time for them to take care of themselves? Mothers are nurturing, absolutely. Perfect, thank you for participating in that. Next slide. So it's very much like what we've talked about, right? Is the expectation that, oh, you're supposed to be a happy mom, your baby is going to be perfect. And this idea that you can't ask for help because the idea is like, oh, you're supposed to know how to deal with things. Like, for example, like the picture in the corner, there's a mom with a baby doing work at the same time and taking care of baby. I don't know how many times people are like, oh, well, I don't know if I could do that. My baby cries all the time. Or what happens if there's a blowout? Like, you're not getting work done. Next slide. And this is the actuality. You're like there's an image of a woman who's like have her hand up, balancing baby in one hand, cooking in another hand, doing groceries. There may be dirty dishes that hasn't been cleaned, baby's crying and you don't know what's going on. It's not this perfect image of either being in pregnancy, childbirth, or even after the fact. Things are messy. Things could be very much out of control depending on what's happening in your environment and support that you either have or don't have. Even if you do have support, it's hard. And we put a lot of guilt, shame on ourselves as moms to be able to do all these things that either family's expectation or society's expectation for us. Next slide. So let's go ahead and talk about perinatal mood and anxiety disorders. Next slide. So PMADs, perinatal mood and anxiety disorders, is not as uncommon as we think. Actually, PMADs is the #1 complication in pregnancy and childbirth. Perinatal depression affects 1 in 7 birthing people. Perinatal anxiety and or depression affects 1 in 5 perinatal people and almost 1 in 2 or 44% of Black and African American people. And it's likely that these numbers are underrepresented because 1, there's not a universal way to screen people, and people may not report their emotional distress. Also, we want to note that death by suicide is the #1 cause of perinatal death within the first year after the birth of the child in the US. And when we think of our system, our healthcare system, we do a really good job like prenatal appointments of assessing for gestational diabetes or preeclampsia or high blood pressure or all these other different measures. But mental health is not always tracked. And let's say they do screen and use a screening tool such as Edinburgh, which we'll go over a little bit later. There may not be a follow-up to the screening. So the provider may not discuss what the score the person had. They may just give them resources and not be able to connect and give that psychoeducation for that person to know like, oh, I'm exhibiting symptoms of depression. I'm getting these resources and why it's helpful for them in their symptomology. And essentially, when we don't provide a great level of care, it impacts the health and outcome of that person, but also the family subsystem that's a part of it. So kind of keep that in mind too, as we kind of talk about disorders in a little bit later. Next slide. So before we go in and talk about the continuum, what do you all know already about PMADs to kind of gauge like how much to talk about versus not? You guys know anything about PMADs or what it is prior to today? There's all like, so I'm just gonna ramble. A lot of people often know like postpartum depression. All right, that's all right. We'll just go right in. Next slide. So before I kind of break everything down, I want to first identify the term perinatal. It refers from the time of conception to the baby's first birthday. Within this time period, there's a spectrum of mental issues that may arise for a person. And in the severity of the spectrum, you have baby blues that are kind of outside of the realm, which is not a medical diagnosis. Then you have perinatal mood and anxiety disorders, which is in the middle. And then the far opposite end, which is more severe, you have psychosis. So if we break down the middle part here of what disorders are classified under perinatal mood and anxiety disorders. First, you have a section of mood disorders. So the mood disorders are major depressive disorder and bipolar disorder. Then in the anxiety section, you have generalized anxiety, you have panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder. Next slide. So this is kind of the spectrum at a glance. Since I've already listed all the perinatal mood and anxiety disorders, we'll go in more detail momentarily. But first, let's talk about baby blues. So baby blues is common and occurs about 85% of perinatal people. The onset is usually within the first 72 hours of childbirth and resolve itself within 2 to 3 weeks. The symptomology is mood swings, tearfulness, irritability, lack of concentration, anxiety, and loneliness. This is very similar when we talk about depression in terms of the symptomology. And baby blues can be treated with sleep and social support. So for perinatal mood and anxiety disorders, generally speaking, it can occur about 20 to 50% of people, perinatal people, either during pregnancy or postpartum or combination of both. The big difference between baby blues and PMADs are that PMADs continue to persist over a period of time, depending on the illness and severity. It can often be treated with a combination of self-help, social support, therapy, and or medication. And the combination for each person will differ on their symptomology and their level of social support. The far end of the spectrum, we have psychosis. So it occurs about 1 to 2 in 1,000 perinatal people. The onset is usually within the first 2 weeks and is often linked to bipolar disorder, major depressive disorder, and lack of sleep. The symptoms are extreme agitation, confusion, hallucination, delusions, inability to sleep, disorientation, suicidal and homicidal ideation, and a break with reality. If you have a client that is exhibiting all of these symptoms, it is a medical emergency and they need treatment as soon as possible. And the treatment can be hospitalization where they're get emotionally stabilized, as well as medication. Next slide. So let's break down perinatal mood and anxiety disorder. We'll start with depression and kind of go up to a higher level of severity. Next slide. So let's talk about the prevalence of perinatal depression. Just like I mentioned earlier, it is 1 in every 7 to 10 pregnant people and 1 in every 5 to 8 postpartum. The rate of depression during the perinatal period is 11.5%. Next slide. So for a person who is diagnosed with perinatal depression, the diagnostic criteria is for major depressive disorder with perineum onset. The person has to have 5 or more of the following symptoms that be present during the same 2 weeks period and represent a change of previous functioning. At least one of the symptoms is either depressed mood or loss of interest or pleasure. So they have to have, mostly every day or nearly every day, they're exhibiting depressed mood, which is either self-reported or observed by others, a marked diminished interest or pleasure in all or almost all activities, significant weight loss when not dieting or weight gain, and weight loss and gain is looked at by percentage. So is there a change of 5% of their body weight within that month? Are they losing a substantial amount of weight? So for example, that would be like, I have one of my clients, she originally was weighed 200 pounds. And at her next appointment with her doctor, she was pregnant at the time, she wasn't gaining any weight and she was in her 2nd trimester. So that's like an indicator, because as they go along in pregnancy, there's supposed to be some level of weight gain, which wasn't happening for her. An increase or decrease of appetite, insomnia or hypoinsomnia, psychomotor agitation, so a feeling of anxious restlessness that cause a person's movement without meaning. So they're unable to sit still, they have a lot of racing thoughts, they pace around the room, they're constantly tapping their fingers, or talk very, very quickly. The next symptomology is fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate, or very indecisive, recurring thoughts of death, not a fear of dying. They have recurring suicidal ideation with either a plan or a suicide attempt, or not a specific plan. There's significant distress and impairment in social interactions with others, taking care of themselves and baby, or other areas of functioning. So let's say they're working, but they can't focus on their job at hand. Or their relationship with their partner, if they have one, is impaired because they have difficulty of communicating their needs, for example. I like this graphic here, and I'm going to read it out to you all. For this graphic, it's a person who has severe major depressive disorder. The air bubble says, "I can't stand the way I feel. I just want to sleep and never wake up. My baby deserves a better mother. Everyone will be better off without me. I can't do this for one more day. I'm not sure if I want to end. I'm not sure if I want my life to end or my suffering to end. Isn't that the same thing?" So this is just some thoughts that people who have severe major depressive disorder in the perinatal period would say and internalize for themselves. So kind of keep this in mind when you work with this population. Next slide. So let's talk about perinatal anxiety. Next slide. Let's first start with the prevalence. So 15.8 to 17.1 of pregnant and postpartum people will exhibit symptoms and be diagnosed with perinatal anxiety. And then less than 5% will be duly diagnosed with both perinatal anxiety and depression. Next slide. The diagnostic criteria for someone who has perinatal anxiety, one of them is generalized anxiety disorder. So they have excessive anxiety or worry or apprehension occurring more days than not for at least 6 months about a number of events or activities, whether it be related to baby or related to their relationship or household. This individual finds it difficulty to essentially control their worry. Their anxiety and worries are often associated with 3 or more of the following symptoms. First one is restlessness, keyed up or on edge, fatigue, difficulty concentrating, or mind tends to go blank, irritability, muscle tension, sleep disturbance. So they're either having difficulty falling asleep, staying asleep, they're having restless sleep where they're constantly tossing and turning throughout the night, or they have unsatisfaction sleep. This has caused a significant distress and impairment in social interactions, their responsibilities, or other areas of functioning. And I want to also go back to this image here for anxiety. It says, in the long run, 1 night or month of my sleep isn't important compared to keeping you alive. The best thing I could do is just watch you all night so I can make sure you're okay. I can make sure that you're okay. What if you forget to breathe? And they're constantly having these thoughts about baby. And I'll go a little bit more detail as we kind of go on. Next slide. Can you play that, please? So this is Amber's story. She's going to talk about her anxiety and panic attacks that she had during her postpartum pregnancy and postpartum. Oh, we can't hear it.
My first pregnancy was rainbows and unicorns, to be honest. And I had a easy birth and.
Is the volume there?
Yes, I can hear it.
Transitioned with my daughter quite fluidly. My biggest struggles actually came in my second pregnancy when I essentially woke up in the middle of the night on exactly 20 weeks and had a massive panic attack. And they just continued. I had 3 more that night, and every time I went to sleep, they just struck. And after about the 3rd day, I decided that I should probably go to the emergency room. And I remember being on the way to the emergency room actually and being filled with such hope that whatever it was, we were going to solve it that night, because that's what happens at the emergency room. You solve everything. I got there and they checked me in, and even the nurse was like, "You're going to be okay." And then the doctor came and told me that there was nothing she could do for me. I was 20 weeks pregnant and I had to go home and figure out a way to relax. So I tried, and it just went on. Pretty quickly, it got to the point where I was afraid to go to sleep. And I was seeing a practice of nurse midwives, and they started giving me different remedies. I was seeing a high-risk OB because I had failed to gain any weight after that because I wasn't eating. So here I was halfway through my pregnancy and not gaining any weight at all because I couldn't eat. and they were afraid I was going to hurt the baby. So I remember asking the high risk OB, like, what does someone do in my position? And I remember this particular OB saying that, you know, some women go on medication, and his wife had some anxiety too, but they knew the best decision was not to do that for them. It felt like there was a lot of pressure from a lot of different spaces to not do that, definitely not do that. So then I started seeing my therapist more. I mean, I feel like I tried every trick in the book. I had like Bach remedies and homeopathics and hypnotherapy and everything you could possibly do to relax. And none of it worked. None of it worked. I just had a safety net. Otherwise, I would have lost everything. I was not functioning. I had panic attacks during the night mostly, sometimes during the day, but mostly at night. And I would jar awake with this feeling of just impending doom, that I was going to die. And my heart was racing and my body was hot and I couldn't get air. And I would usually go find a window and like open it and stick my face against the screen and try to like gasp for air because I felt like I was suffocating. It wasn't until I had these repetitive panic attacks that actually I realized I had them as a kid, not in any way, shape, or form as frequently, but that's what they were. But it's this feeling of just lack of control over your body and mind. And when they keep occurring, there's like, it becomes traumatic and you want to avoid it by any cost. So you start thinking you have like tricks to defeat it or ways around it or something. But truly all you're trying to do is prevent this feeling of you're dying happening. Because that's what it feels like. It feels like you're dying. And when they happen over and over again, it begins to feel like you're falling apart, like you're kind of in a continuous stage of dying. I just wanted to sleep. And I felt like if I could just sleep, I could make it better. And I'm sure I wasn't the best parent to my daughter at that time, even though I think she actually brought me the most solace and distraction out of everything in my life. I actually think the times I felt the most grounded and centered were with her. I remember reading a book to her every night. I loved reading to her and feeling peaceful with her, but I also knew that once she went to bed, my night started. And I didn't have her as a distraction. I had to think about how I may never sleep again. So like it permeated everything. My marriage. I think I scared my husband. He didn't want to be around it. It was too much for him. It was just too much for him. Yeah.
Right here.
Which it's hard on the people around us, but when you're the sick person, you're already struggling with whether or not you are okay or going to be okay or worth being okay, worth fighting for. I basically had one close friend and my mother that I felt I could be completely honest with about how bad it was. Other than that, I was honest with my therapist and my midwives, but it seemed like the same answer over and over again of stop working, stop stressing. There was nothing strong enough that was deemed 100% safe for a pregnant woman. So I just continued. So I finished out my pregnancy like that. And then I had this idea that once my son was born, it was all going to go away. I remember even like birthing him and thinking I was so still in that space and not even, I'm birthing a kid and I'm thinking, oh, this is going to be great because I'm going to feel okay after this. But it continued. And then adding to the complexity, my son was born with a congenital defect that the nurse midwives had never seen before and the pediatrician had never seen before, even though now I know it's actually fairly common. So the first few days were this chaotic experience of, wow, I've never seen that before. What's that? While I'm trying to deal with everything else. So my level of lack of control and trust in all of the people that were supposed to have the answers for me just was obliterated by then. I felt like no one could help me. There was no hope. After my delivery, it continued. I just was feeding a baby at night, and that distraction helped sometimes. But I continued to have panic attacks. I think also because I had this idea that there's postpartum depression, and that's it. There's no category other than that. And because I wasn't depressed, I was anxious in every fiber of my being, but I wasn't quote unquote depressed. I felt like there wasn't a space for me. Like I wasn't allowed in the postpartum depression group because I wasn't depressed. And I felt like during my pregnancy, no one ever talked about perinatal or prenatal mental health issues. And when I asked the experts, everyone said I just was stressed. And of course I was stressed. I was having a second kid. So I ended up in this postpartum support group, and the woman who runs it, who was a very well-respected specialist in postpartum and perinatal and maternal mental health. I mean, she took me aside and gave it to me straight. And it's like, you're really trying to hold that together and you know what you're doing, but you're sick. You're really, really ill. And I know what I can do to help you, but you need to let me, and you need to take care of yourself. And I finally said, what do I have to do? I remember asking her, is this forever? Because that's what it felt like. And she said no. She seemed so confident. I didn't know if she was just full of shit or what she was full of, but I really wanted to believe her. So I started seeing her. I thought, why not try someone who has a specialization in this? And I eventually got on medication, which changed everything. And I remember before I got on medication, asking basically everyone in my life for permission to do it. Because I felt like at that point, I think I honestly felt like I didn't deserve it. I didn't think anything would work. I didn't feel worthy of whatever was to come next. You're the last person that can make those decisions for you, it feels like. I was the last person who was able to help myself until I bridged that divide and was able to feel what it felt like to feel better. And once I had a sense of that again, I was able to work on everything else that got me there, that had brought me to that moment. But it wasn't until I literally was able to breathe again that I was able to do any of that. And I really do believe that without that, I don't know if I would have made it. I remember it was after after a set of remedies that were supposed to help. I did get to a place one night where I just thought, if there's nothing, I don't know how much longer I can do this. But I do remember I only told one person that I got there, and that was my husband. And I don't think he was ready for that. So I've thought about how the system has failed me, I guess you could say, in a lot of ways. And I've also realized how ill-equipped the system is. More than it's failed me personally, I think people just don't know what they don't know. And the high-risk OBs that I saw when I needed to get my ultrasounds done because my son wasn't growing the way they thought he should, gave me kind of lukewarm, yeah, but kind of most women just need to soldier through what's going on in their pregnancy advice. And I remember thinking, if women are soldiering through this, we are failing women. I felt how this must affect children, your spouse, your family, your work, how how your children interact later on in their, just all of it. Like I could see the echoes and the ripple effect into the future. There's a reason why our society in some ways is struggling. It made me feel like this is it, actually, is we're failing our women in this pivotal time in our lives, and everyone suffers for it. One thing that came out of this experience that's so positive is part of that dedication of this I cannot look away ever again, was doubling or tripling down on my advocacy work for folks experiencing homelessness, especially women. I understood how much of this, especially from working with people on the street, how much of this was women who had been failed and who spiraled out of control without a safety net, or talking to people on the street and realizing they're the children of women that this happened to, or families that this happened to, and their family was never able to rebound from it, and the level of trauma they went through. It just made me so much more aware of the struggle of any place on the spectrum of mental illness, and not having the support that's
O
needed.
sea, a ver, a los no está, y Maybe está, y Juan Luis también, y todo eso.
I've been across a woman who is experiencing what I experienced. I would beg her and encourage her to get the help she needed, and that I would convince her that it's there. And I'm so sorry if you have to dig for it. I'm so sorry it's not just there, but reach out to someone who knows about this. I mean, we have maternal mental health now. We have networks around this. We have specialists. Find them. And I would almost say, don't listen to anyone else. Find who actually knows about this, someone who does, and trust them. And I would remind her, like I remind every woman that I see struggling in any way through this, that you are so worth it. Speak up when you're down.
Before we move on, any thoughts or comments about either Amber's story or anything we talked about, either perinatal depression or anxiety so far? You can put it in the chat or unmute yourself, whichever you feel comfortable doing.
My name is Amber Sheik Ginsburg, and I have 2 children.
Okay, so let's go ahead and move on to talk about perinatal obsessive compulsive disorder. Next slide. So the prevalence of perinatal OCD is 2.9 of perinatal people develop OCD overall. Is an increase in pregnancy and early postpartum by 8.7%. Next slide. So when we think about obsessive compulsive disorder, we need to break down of like, what is obsessions, what are compulsions, what do they look like, and the manifestation for a person who has obsessive compulsive disorder. So first, obsessions are reoccurring, persisting thoughts, urges, or images that are experienced that sometimes during distress or unwanted or intrusive thoughts. In most individuals, as a mark of anxiety or distress, individuals attempt to ignore, suppress these thoughts, urges, or images, or neutralize them with other thoughts or actions. Compulsions are repetitive behaviors such as like hand washing, ordering, checking, or mental acts such as like praying, counting, repeating things, or repeating words silently to themselves. The individual feels driven to perform in response to an obsession or according to rules that must be applied very rigidly. The behaviors or mental acts are aimed to prevent or reduce anxiety or distress, or preventing some dreadful event or situation to happen. However, these behaviors or mental acts are not connected in a realistic way, that they are designed to neutralize or prevent, or are clearly excessive. So I want to actually go back to the anxiety slide. And go back to that graphic. So imagine for someone who's exhibiting obsessive compulsive disorder, they're sitting right at the baby's bed, looking down at them. And imagine they're thinking this: I have to check baby. I have to check the baby. Are you breathing? You're not breathing. I just checked. I don't see your chest going up and down. Oh my gosh, you're not breathing. Oh wait, I see your little chest rising. You're breathing. I'll just stay here. The best thing I could do is just watch you all night to make sure that you're okay, just in case you forget to breathe. So that kind of gives you an idea of like some thought patterns for someone who's exhibiting OCD. Okay, can we go back? Right here, perfect. So what are some presentations for those who are exhibiting obsessive compulsive disorders? So they have contamination. They're pretty much fearing that there will be some type of harm to infant. Example of that, I had a client who would prepare the baby bottles in a certain way because she fears that like she would poison the baby if it's not washed a certain way, dried a certain way. If she didn't put the bottles inside a pot and let it boil for a certain amount of time. And if anyone else didn't do it the way she did it, it caused her to get very upset and angry at either her spouse, and her grandmother was there to also to help her, and she will like flip out on them very quickly because it wasn't done the way she wanted to be done. And also she had thoughts about like, well, if it's not done this way, then baby's going to get sick, and then it's something bad about me because baby is sick. They may have so another presentation is harm as a result of parental distraction or neglect. Unwanted images or thoughts about behaving sexually with infant. Unwanted thoughts or harm to the infant on purpose. An example of that would be, I had another mom who, as she was pushing the baby in the stroller, she thought of like, what if I just let go? And then that was very alarming for her. She's like, oh my gosh, what if I let go of my baby and something bad happens? And that like caused her to freak out even more. And she intentionally avoided taking baby out of a stroller. She always had to wear a baby on her body. Other presentations is checking, arranging, and ordering. I had another client who at one time she left the stove on after cooking a meal for herself. And her husband came home and was like, oh, why'd you leave the stove on? Ever since that incident, she would go back. When she's in the kitchen, she'll check repeatedly. Like after she's done cooking a meal, she'll check at least 2 or 3 times. And then let's say she's washing the dishes, she would go back and check the stove. And it was like repeat throughout her whole day of going back. It was like, oh, I don't want to forget about the stove. And then what if something happens because I left the stove on? Next slide. So here's another story for Jennifer. She had history of postpartum OCD.
There's no avoiding this illness because for me, it just kept getting harder and harder and worse and worse. I just remember the first time when I was driving, I had an incident with this white plastic bag. I saw it on the side of the road and I thought it was something. Like my brain was telling me, what if it was a baby in a bag? What if I hit it? What ifs just kept running through my head. So I'd circle back and check on it. And then I'd circle back again. And it took me 45 minutes to get off that road. I chalked it up to hormones or the thought of maybe it's just because I'm going to be a mom and I'm nervous about things. And then from that point on, driving was really complicated. It was all the actions that I did that equated to my condition. It took me 40 minutes to shower. Why? I had to, but I had to make sure I was clean. And every time I tried to get out of the shower, I had to get back in again. And then I kept saying, well, I can't touch the baby if I have dirt on me. And so then I would get back in again, and then I would come back out, and then I had to get back in again. And so 40 minutes later, I just took 40 minutes to shower. And to be honest, never really felt perfectly clean for her. And so all the little things that somebody would do on a day-to-day basis now took so much energy for me to do. My husband and I both fed Alex. And the one time he was cleaning something with cleaning product, just something in the kitchen, something basic, a kitchen cleaner or whatever. And he washed his hands. And then he was going out, so he said he would make up Alex's bottle. And that's fine, that sounds great. So he made up her bottle, and then all I kept thinking was, he didn't wash his hands well enough. And I kept saying, did you wash your hands? And he'd say, yes. And then I'd say, I don't know, did you wash your hands? And I would think I repeated it 10 times. And then I kept saying, what if the cleaning product got into the bottle? What if the chemicals in there and would make her sick? And it got to the point where I was sitting there holding her and about to feed her, and I couldn't do it. I was literally paralyzed because all I kept thinking was, I'm going to poison my baby. And she's going to die. And all because he didn't wash his hands right. It just all sounds so ridiculous, but that's how I felt. And he had to go. So he's like, are you all right? And I said, I guess I'm fine. And then he left. But that feeding her was excruciating because all I kept thinking was, oh my God, I can't believe I'm giving her this bottle. Like, how could I possibly do that? From that point on, every time I made a bottle, it was so painful because I had put this idea in my head that I could possibly poison her with something. I couldn't sleep all night. This is something that had gotten worse, which is surprising because I felt like I had actually said something and I was going to get help, but something had gotten worse in just a matter of a half of a day. And I stayed up all night. And then the next morning, I said to my husband, well, you can't go to work today. I can't be left alone. My dad was coming over to help me, to take me to the appointment. And then at that moment when he came in, he gave me a hug, and very quietly, I just said, I just didn't think that I belonged here anymore, that maybe it would just be better if I wasn't here. Sitting there waiting to get my appointment, and I walk in and I meet the counselor, and she looked at me and she said, And she gave me a hug and she just said, I know what you have and you're going to be okay. For some reason, I felt like I could believe that. And then she gave me this checklist of OCD tendencies. And for the very first time, knew what I had because everything on that piece of paper was what I had been doing and all the things that I had feared. And it was like, oh God, it's the first time I could breathe. I could just breathe because someone told me what I had. Someone told me I would be okay. And I felt like I could have hope again.
Any thoughts related to this video, or as we talked about anxiety? No? Okay. Let's go ahead and move to the next slide. If anything does pop up, if you have questions or whatnot, feel free to just put in the chat, and at the times when we have a pause, we'll review them.
Do you mind if I throw a comment in?
Yeah, go ahead.
Okay. I was just thinking over and over again, what stands out to me is that people feel such a relief when they discover that others feel this way. They're not the only one, and that there's a set of symptoms. There's something that they can call it and they can start to address it. That feeling like you're the only one, I think it adds so much to the detrimental effects of how you're feeling.
Yeah, I can't agree more. It's that isolation, like they have to do it on their own, pull themselves up by their bootstrap because of those perceptions of what it is to be a mother or a parent. Great, thank you, Carol. Anyone else have any thoughts about that video or the video before, or really any of the content we covered so far? Someone said, I agree. Just how awful that prolonged isolation must be until they get validation. It is absolutely. Well, thank you. Oh, go ahead, Kara.
I'm just going to say again, it points again to how, this is a topic that doesn't get discussed enough, and people are trying to rectify that and make it normalized, that this is out there, this is how people feel, it can happen. And there's so many taboos about talking about not feeling wonderful when you're a new mom. So, I think people are helping to change that, but that's something that really stands out to me too. Yeah.
Well, thank you for sharing. Yeah, it's a great need. We need more mental health professionals. We need healthcare providers to provide adequate care prenatally, postnatally. 100%.
I just had a question about when these issues persist, like are they supposed to go away after a certain time period, or they can become
yeah, it depends on their severity of their illness. For perinatal mood and anxiety disorders, it tends to go away after time. And treatment also may help, or self-help, or just having that social support group. Either it's like they're part of their system or outside of their support system. So kind of like validate, like they're not alone. There is ways that you can overcome if you're anxious or you're depressed. There are some disorders within perinatal mood and anxiety disorders that don't necessarily go away, and we'll talk about it. It's bipolar disorder. Any other questions? Perfect. So let's go ahead and talk about perinatal post-traumatic stress disorder. So the prevalence of perinatal PTSD is 3.3% in pregnancy, and after birth, 4%. There's actually research that talks about if someone experiences a traumatic birth, it's actually 30% of those people who experience traumatic birth actually develop PTSD. Next slide. So when we talk about PTSD, the diagnostic criteria is first the stressor. So either is the person themselves experiencing the traumatic event, others who are witnessing, could be the spouse, it can be whoever's their birthing team, whether it's their doula, the nurse at the hospital, the OB at the hospital, all of these people can simply interpret this as a stressful traumatic event. If they've learned about the trauma occurring to like a close family member or friend, that can be traumatic. Experiencing repetitive or experience exposure to adverse details of traumatic events can be very hard as well. Next slide. The next aspect of the criteria is intrusive symptoms. So reoccurring involuntary intrusive memories or dreams, flashback, intense and prolonged psychological or physiological distress as it relates to the reminder of the event. Avoidance. So you may avoid reminders associated with the event, thoughts, feelings, people, place, objects, conversations, situations that arose the stressing memories, thoughts, and feelings related to a traumatic event. So an example of that would be of course, I'm going to bring up my clients. One of my clients, she had a traumatic birth at a Nova, one of the Nova hospitals, and she avoided going any vicinity around that Nova hospital because it reminded her of the bad thing that happened to her, which was the traumatic birth, and the feelings about being not having control over the situation, not having conversations with the healthcare providers. She also avoided her OB as well because she didn't feel safe to just talk to them because things happened so fast for her that it was traumatic for her to even go to her 6-week postpartum appointment. But she would go to her pediatrician appointments for her baby. Next slide. So negative ordination in cognition and mood. So difficulty remembering aspects of the traumatic event, negative thoughts or feelings leading up to ongoing or distorted beliefs about self and others. So that may be thoughts of I'm a bad mom, no one can be trusted, the world is completely dangerous, my body failed me. That's often a theme I hear is my body failed me, something's wrong with me. Other things, they will blame themselves or other people. They have negative emotional states such as fear, horror, anger, guilt, or shame. There's a loss of interest, detached or estranged from other people who were part of their social support system. And then inability to experience positive feelings, which it could be unable to feel happiness, satisfaction, or loving feelings. Even if if someone else is displaying those feelings to them, they have a struggle with reciprocating that. And then alterations in arousal and reactivity, so irritability, anger, aggression towards others or people, recklessness, self-destructive behaviors, easily startled, problems with concentration, difficulty falling asleep, staying asleep, or even having restless sleep or unsatisfied sleep. Next slide. So here is just a list of traumatic events that a person can experience. This is not an exhaustive list, but one of the big ones is any deterrence from the birth plan can be traumatic. For example, I had a client who thought that her birthing would be very serene and calm. So she thought that she'll birth naturally, no medication in the hospital, but it didn't happen that way for her. She actually had to get an emergency C-section which was not planned. She didn't actually know what was happening because things happened so fast for her. And the providers also didn't communicate why she needed to go to surgery and have a C-section. Prolapse cord, that could be unplanned, planned C-section, like I mentioned. The use of vacuum extractors, forceps, or really any assisted birth devices, even if it's like, for example, I had a person who had a placenta that was intact after she delivered her baby, and the doctors initially started by pulling the placenta out of her before using other means, which was traumatic for her because she was like, well, what's happening? And I'm feeling a lot of pain due to this. And she also hemorrhaged too, which also didn't help. Baby being admitted to the NICU, and it doesn't matter the amount of time the baby was admitted into the NICU, whether it's 1 week or 3 months, it's still a traumatic experience for those people. And it also, you also think about when we talk about trauma, it's based on their perception of the traumatic event. Feelings of powerlessness, poor communication, lack of support, reassurance during birth. There could be severe physical complications due to like hemorrhaging, unexpected hysterectomy, severe eclampsia, or being diagnosed with eclampsia in postpartum, perinatal tears, the duration of labor and delivery, because depending on the person and their body, for some, labor and delivery can be very quick, whereas others, it can take days for them to go through the process of labor and delivery, and it could be taxing on the body itself. Or loss of decisions. Also, if there's like, if the person had to deliver a baby who's stillborn, that is also traumatic. There's a continuum of different things, but this is just a short list of that. Next slide. So now we're going to listen to Caroline's story.
My name is Vanessa Hernandez, and I have a 3.5-year-old boy, and his name is Noah. He was born July 26, 2016. I had to get emergency cesarean because my placenta erupted. So that process was difficult because I also almost lost my son that night. To see my son in the NICU, I felt hopeless. And then I didn't feel that connection. Yeah, I didn't feel that it's the mom connection with her son that I wanted, because I couldn't pick him up. I had to wait for the nurse to pick him up and give him to me. And even when he was in my arms, I just couldn't hold him. I just had wires everywhere, a board on his arm. Then once I got home, then I wasn't expecting all the feelings that came with it. The sleep deprivation, the anxiety, worrying, crying often. So until like a month later, that's when I realized that my baby, what I was feeling wasn't the baby blues. I realized it actually when I was watching a show. I was watching Grey's Anatomy, and the doctor was losing her baby. And she actually lost her baby. So that took me back to my birth night. So it was like a flashback to that night when I almost lost my son. So in that moment, I just started crying, and I realized, oh my God, I'm traumatized. I did seek help. I let my husband know that same day what happened, and he helped me find a therapist. I'm actually a marriage family therapist. So that helped me realize like my symptoms right away were not the typical baby blues. I was actually traumatized. So that helped me seek help right away. And so once I was in treatment, the therapist made me aware also, like, I wasn't just grieving, that I was grieving my expectations. It wasn't just what happened that night. It was also everything I expected my birth to be, grieving the loss of my expectation of my birth. And I thought I resolved it. I thought I felt better. So I stopped therapy. So that was in 2016. And then in 2018, it got triggered. My trauma was triggered. My just depression was triggered after my second miscarriage. So the second one really impacted me because I wasn't expecting it to have a second miscarriage. I actually felt contractions, like the whole labor process. And to realize at the end, it just kind of flushed out of me into the toilet. So it's kind of like going through the whole labor process. And at the end, you have nothing. And that was difficult. So I think that, that triggered my trauma from my birth and went into depression. But I kind of just put myself aside so I could be present for my son. But I say, I was in a dark place, but at the same time, I needed to be the light for my son because I just know how important that was and still is for me. That, he'll pick up the way I'm feeling, and I don't want him to see me down. At that time, he was 2. So I think he kept me going. He was my why to get better. I didn't realize how depressed I was, but that depression, I got depressed and became anxiety as well. And I just use all my energy every day just to be present for him and be there emotionally, physically present. And that's all that mattered. And then I noticed when he started preschool, I had more time for myself. And then I noticed my own feelings. So that's when I started working more on myself and getting better. And I went back to the same therapist for my birth experience. I reached out before it got worse. I had nightmares for about 4 months, daily nightmares, fears that something bad was going to happen to my son, fear of him dying. I did have fears of suicidal thought, which at the time I knew I wasn't suicidal. I just wanted to escape. And I was even hesitant to tell my therapist, like, okay, I'm not going to tell her. I was thinking like the worst case scenario that can happen. So my thoughts went irrational. My thoughts also went to like, I won't tell my therapist because what about I get put into psychiatric hold or DCFS or Child Protective Services will be called to see if I'm a good, mom for my son. So those thoughts came to mind, and I did let my therapist know after all that, I had a suicide thought. And unfortunately, she had enough experience to know that I was not suicidal. I didn't have a plan. It was more of wanting to escape how I was feeling, which is really, I was exhausted. What helped me realize is just my background in mental health, that I knew that what I was feeling, it was being my trauma from my birth was being triggered, but at the same time, I did need that help. I did need the help from a professional to help me process what the triggers were and why were they coming up again. I started doing, things I really didn't want to go. I didn't want to go to any social events, but I said I would and I went to, even though I didn't feel like going. I woke up in the mornings for my 5 a.m. workouts, which I didn't feel like going, but I knew that would help me because I was surrounded by support. I went to church, even though I was angry at God, and I didn't feel like getting up, but I went. So what helped me was doing it. Even though I didn't feel like doing it, I did it. That and my faith got me through that depression and anxiety. Something that I would let moms know if they're experiencing like symptoms of trauma or depression, is asking for help, speaking up. That was very difficult for me. I always want to handle my own problems, and I'm a very private person, and I don't like to be vulnerable. But this process taught me to be vulnerable and taught me to ask for help. That's very important. With moms, I know it's like ask for help. Once I started talking to moms, everyone's had the same feelings. So that's what I found out. It's very common and you're not alone, and ask for help. Just speak up when you're down.
Any thoughts about Caroline's story? PTSD?
No, I was just gonna say that I appreciated her, mentioning the fact that she was feeling these feelings, was, feeling thoughts of suicide. She was connected with someone that knew enough, to be able to help her and make, because I think that a lot of people do have that fear to express whether it's thoughts of suicide or just, seek help. Because they are afraid that like DSS or others are going to get involved. And so, kind of have to normalize that if someone's having those thoughts, doesn't mean that they're going to be whisked away to a hospital or that their child is going to be taken away. So, I just, yeah, that was my takeaway there.
Perfect. Well, thank you for sharing. And also it's important, like us as healthcare providers are aware, like people will have these thoughts. Just because they're having these thoughts doesn't mean that they're going to actually harm themselves or other people. And how do we appropriately assess the situation before taking action?
Exactly.
Any other thoughts? Okay, let's go ahead and move on to the next slide.
My name is Vanessa Hernandez.
So let's talk about bipolar disorder in the perinatal period. Next slide. First, let's talk about the prevalence. Oftentimes, people who actually have bipolar disorder are misdiagnosed for major depressive disorder. And more times or not, the misdiagnosis happens because of the assessment tools that are used. So oftentimes providers will use the Edinburgh, which is the postnatal depressive scale, which doesn't assess for hypomania or mania symptomology. So they're only getting one piece of the puzzle. And it is important when we're talking about those who exhibit bipolar disorder is doing a very good psychosocial or initial evaluation for individuals in the perinatal period in general, but specifically for those who have symptomology or bipolar disorder. 22.6% of those who screened positive on the Edinburgh actually had bipolar disorder. 50 to 70% have reoccurrence of symptomology in postpartum. And for some people, this is the first time, like the perinatal period is the first time that they've ever been diagnosed with bipolar disorder, or there's a relapse during pregnancy and postpartum if they've previously been diagnosed with bipolar disorder. Next slide. When we talk about bipolar disorder, it's likely an underlying undiagnosed condition triggered by pregnancy and postpartum. That's why some people, this is like the perinatal period is the first time they've actually been diagnosed with bipolar disorder. And this disorder essentially causes changes in a person's mood, energy, and ability to function. For bipolar 1, there must be an episode of manic followed by either hypomanic or depressive episode. Manic is like agitation, decreased need for sleep, racing thoughts, increase in productivity. So like they feel like they could save the world. And it's often noticed by others. Their speech may be very pressured and they have like high energy. Severe functioning impairment and psychotic symptoms such as hallucination, paranoia, and disorganized thinking can happen when someone has a manic episode. And if this is happening for a person, it requires hospitalization. Hypomanic lasts up to 4 days, is often improved in functioning. It's still high level of anxiety, a lot of energy and expression, but it's not as significant as manic. Depressive episode, symptoms have to be present during the same 2-week period and represent a change in previous functioning. And this is the symptomology of depressive episodes, very similar to when we talked about depression. Next slide. Then we have bipolar 2. There must be a current or past hypomanic episode and current or past depressive episode. So hypomanic episode is periods when mood is much better than normal, like I mentioned earlier. There's rapid speech, they have little need for sleep, racing thoughts, trouble concentrating, there's some level of anxiety and irritability. They may exhibit what we in perinatal field call kind of like postpartum or perinatal rage. There's a continuous of high energy and they have like the overconfidence. Extreme degrees of behavioral change or difficulty with daily functioning and social interactions disrupts a person's relationship with their loved one and causes difficulty with taking care of a baby, working, taking care of themselves, or any other aspects in their functioning. Their mood can be triggered by stress, sleep disturbance, and substance use. So keep that in mind when you guys work with those who exhibit bipolar disorder. Next slide. Now we're going to go to the far end of the spectrum, which we have is postpartum psychosis. Next slide. It occurs, like I mentioned earlier, 1 to 2 in 1,000 postpartum people. Relative risk is 23 times more likely than other times in their life. So it's something about the perinatal period that causes a person to exhibit symptoms of psychosis. Next slide. So the diagnostic criteria for those who exhibit postpartum psychosis is psychotic disorder. They have to have presence of one or the following or more of the following symptomology. So delusions or fixed beliefs that are able to change despite conflicting evidence. So an example of that would be like, let's say they're out and about and they see signs of like, you're supposed to wash your hands, especially in COVID, right? There's always signs about washing your hands or using hand sanitizer. For them, they'll think it's about me, so I have to wash my hands. They may view ads or commercials on TV and think that those ads and commercial is talking to them directly. Their thought patterns or their delusions may or may not contain violent demands, and not all thoughts are destructive. They may have hallucination, which is perception-like experience that occurs with external stimuli. Example of that would be, I had a client who every time she goes to bed, this dark entity will come in her room and it'll be in the corner of the room. And it prevented her to sleep because she was afraid of this dark entity, even though this dark entity didn't say anything directly to her, but the fact that it was present in the room impacted her. Next symptomology is disorganized speech or thinking. So derailment, loose association. So like they move from like one topic to another really fast. So like, let's say they're talking about someone's hair, and then they'll start talking about the sweater, and then they will talk about the weather outside, and then they will talk about how their clothes feel on their body. It's not like those different topics that they're bringing up has no association with each other whatsoever. The next is grossly disorganized or abnormal motor behavior. It could be unpredicted agitation, catatonia, which is lack of movement and communication, agitation, confusion, and restlessness. There's a heightened sensitivity to sleep deprivation for those who have psychotic disorder. There's a decreased need to sleep, or they're having difficulty even going to sleep at all. They may also experience symptomology of either hypomania or mania. With this disorder, you can also use the specifier as of postpartum onset, whereas like depression, OCD, you can use perineal onset. Essentially, there's not much of a difference in terms of like the explanation, other than that for both of those specifiers, the symptomology has to be occurring during pregnancy or 4 weeks after delivery. Next slide. So let's talk about the difference in thought patterns and thinking patterns for those who exhibit obsessive compulsive disorder versus those who exhibit psychotic disorder or psychosis. Those who have OCD, intrusive thinking, such as like dropping baby, letting go baby, letting go the stroller in traffic, or using knives to harm baby. The OCD patterns are ego-dystonic, which essentially means that the thoughts are inconsistent with what the person believes to be true and cause great alarm and distress for them. And they're afraid to act on those thoughts. Whereas for a person who exhibits psychosis, their thought pattern is, I can only save my baby by killing them. The devil is telling me to do it. You are videotaping or filming me. These thought patterns tend to be ego-syntonic, which essentially means that the thoughts of them make sense to them. They're not alarmed or distressed by those thoughts. And they actually have a strong desire to act upon those thoughts. So that's why it's very important, like if you have someone exhibiting symptoms of psychosis, it's a medical emergency and they have to get treatment as soon as possible. Whereas those who have obsessive compulsive disorder, yes, they need to get treatment, but it's not as extensive, may not be as extensive as the person who is exhibiting psychosis. Any questions? All right, let's go to the next slide. It's a video about Andrea Yates. I'm not sure if you guys remember her, but she was heavily like on media because she killed her children. And it came about that she actually had postpartum psychosis.
The new mother.
Hello.
Mother for the 5th time.
This home video of Andrea Yates was taken by her husband Rusty just after she gave birth to their 5th child, Mary, last November. It was just 7 months before she would kill her baby daughter and her 4 sons.
Say cheese.
2-year-old Luke, 3-year-old Paul, 5-year-old John, and Noah, who was 7.
Everybody say goodbye. Back to the camera.
Bye.
It is hard to comprehend that this 37-year-old woman, a former nurse and high school valedictorian, who has been described by everyone who knew her as a devoted and loving mother, is the same person who is charged with capital murder. The person who has the hardest time comprehending all of this is her husband.
She's a terrific mother, loved the children. They're always climbing up in her lap, and she'd read books to them, and just all kinds of stuff, and she loved them. And so I knew that there's no way, there's just no way that she would ever do anything like what happened.
But she did.
No, but it's because her mind was sick, that's it.
Although there were indications that her mind was sick, Andrea Yates never gave any signs that she intended to harm her children. But after her arrest, she told authorities that on and off the past 2 years, she'd heard voices telling her that the devil was after the kids and that she needed to save them. She said they were, quote, hopelessly damaged. And on the morning of June 20th, Andrea Yates waited to act until after her husband left their home to go to his job at NASA's Johnson Space Center in Houston, where he's a civil engineer.
Well, I got a phone call from my wife at 5 till 10, and she said, you need to come home. And she sounded really like very stern, very cold. I said, what's wrong, Andrea? And she said, you need to come home. And she hung up. And I was really getting nervous because of her tone. And I called Andrea back at the house, and she picked up the phone. And I said, Andrea, what's wrong? I said, is anyone hurt? And she said, yes. And I said, who? And she said, the kids. And I said, which ones? She said, all of them. And I was just devastated.
According to what she told police, Andrea Yates had filled the family bathtub and methodically drowned her 5 children. And she dialed 911. By all appearances, the Yates were a normal, happy family until 2 years ago. Soon after the birth of their fourth son, Luke, Andrea began showing signs of depression. Twice in 1999, she tried to kill herself, first from an overdose of sleeping pills, and then a month later, she took a knife into her bathroom.
She had a knife held up to her neck, and it's like she's looking at her neck trying to figure out how to cut herself so that she could successfully kill herself. And I said, "Give me the knife." And she said, "Let me do this." And I said, "No, give me the knife." And she wouldn't do it. She just stood there like this. So I grabbed her arm and pulled it down, and I pried the knife out of her hand.
The next day, Andrea Yates was admitted to a psychiatric hospital. She was there almost 3 weeks and diagnosed with postpartum depression with psychosis. About 75% of new mothers experience some form of postpartum depression. It's commonly known as the baby blues and usually fades away in a few weeks. But Andrea Yates fits into a much more severe category that affects less than 1% of women. They may either kill themselves or their children. Andrea Yates seemed to fit that profile perfectly. There's no evidence that she abused her children, but during her hospitalization, she described being stressed trying to raise so many young kids, saying it was a big responsibility. I don't want to fail. According to hospital reports, she said she had recurrent obsessive thoughts and that most of them are over our children and how they'll turn out. She was treated with 2 antidepressants and an injection of the antipsychotic drug Haldol. Her husband, Rusty, says the response was remarkable.
Within a day, Andrea went from being completely catatonic to sitting on the couch with me in the visiting area, and we carried on just, I referred to it as the best conversation we've ever had. The thing I learned from it is that she needed the right medicine. When I saw her respond to the medicine at that time, I'm like, wow, there's hope. There's hope that Andrea will return.
After returning home, Andrea Yates was soon back to the job of being a full-time mom, which she appeared to enjoy.
Bringing up the rear is Luke. Hello. All right.
She shot this home video of her children playing around the house.
This is our night ceremony here.
Andrea Yates homeschooled her oldest children, even designing their sets and costumes for a lesson on medieval history.
Okay, Sir John Yates. And he will go to his castle.
She also cooked and cleaned the house. Her doctor suggested she get some help taking care of the children and that she devote some time for herself. But Rusty says she chose not to. For more than a year after she got out of the hospital and was off all medications, by all accounts, life in the Yates family was back to normal. They decided to have another child.
There's the baby here.
Ignoring a doctor's written warning which said that doing so would surely guarantee future psychotic depression.
Well, no, we looked at that and we said, well, this was a very difficult time. But then we said, well, would we rather have not had Luke? I mean, of course, we'd rather have Luke and have gone through that. What we were told is that there was a 50% chance that she would be depressed again if we had another child. And if she got depressed again, she would have the same symptoms as she had in 99, and that the same treatment that worked for her in 99 would work again.
Within months of Mary's birth, Andrea Yates' depression returned with a vengeance. It was a depression which her husband says led her to murder their children.
Any thoughts?
I mean, I just can't believe that the doctor, said there's a strong likelihood that if you have another kid, this could trigger an episode, essentially. So is there, I'm trying to figure out how to frame this question. I have Friday brain. So is there like a greater likelihood, I guess, I'm just curious. I'm thinking of even some friends that I know that have had multiple children. Sometimes I feel like by the third child, oh, my friend is a little bit, their baby blues or, depression definitely, it shows itself, after that last child rather than the first or second child. Is there any correlation with that or likelihood that that happens more the more children you have?
Not necessarily. It's based on like what the risk factor for that person. So for Andrea, she already had that history, and we don't have the information to really divulge into like what was like her history prior to being
Right.
pregnant. Like, did
Yeah.
she have symptoms of bipolar disorder that
Mhm.
was missed, and they labeled it as depression? Or what was her family history? Like, does it kind of like run in her family? Oftentimes when we think of like PMADs, it kind of like if your mom had some type of perinatal mood and anxiety disorder, there's a strong likelihood that you may develop it. And in
Okay.
her situation, it seemed like for Andrea, she didn't have that support in the household, even though she was like, oh, well, I don't want to do that. She had 4 kids and she was having 5 kids. That is a lot.
A
With
lot.
already having that history on top
Yeah.
of that increased responsibility.
Well, that was kind of my thought too, is we're getting the dad's side of the story at this point.
Mhm.
And so it's like, he's saying she was great. Well, guess what? She wasn't, obviously.
No. Mhm.
So
Yeah.
you guys deciding to have another baby and ignoring the doctor, now you're trying to justify your decisions. Like,
Mhm. Yeah,
another woman just got failed, and who knows what was going on in the house besides that.
exactly. Yeah. Absolutely right.
Yeah, I mean, I'm somewhat, I didn't know the details quite of, that situation. I just remember like that being in the news a while ago. But it was shocking to hear that it had happened. And then obviously the doctor strongly advised and said, like, this is going to be another super duper high chance it's going to happen again. If you become pregnant, you're going to be really vulnerable to this happening again.
Mhm.
But also, yeah, just like hearing just the marital stuff probably too going on, just that disconnect of like,
Mhm.
let's have another kid, like just crazy. I didn't know that part of the story.
And who knows if it was an unintended pregnancy, that also puts in another factor in there. Like, well, I wasn't intending to be pregnant, but now I'm pregnant. What were their like religious background or spirituality around and beliefs around pregnancy, and how would that also attribute to like her symptomology? So many facets we could like divulge in for this story, or really what perinatal people or women who experience postpartum psychosis. All right, let's go ahead and go to the next slide.
The new mother.
Hello.
So this is what we're kind of already getting at when we talk about risk factors and predictive factors for perinatal mood anxiety disorders. Next slide. So as we talk about PMADs, we need to understand what biological, psychological, and social factors play a role in a person developing symptomology of PMADs. The biological factors, we need to consider their personal history, whether it's their mental health history, substance use or abuse history, reproductive history, which could be very extensive when we talk about infertility, their menstruation, if their symptomology, like some people who are menstruating, they may have high level of emotional states. They may be very depressed or very down during their periods. What was their pregnancies like? What were their loss if they have pregnancy losses? Ovarian syndromes or symptomology, do they have like severe PMS? Were there any complications in their pregnancy, labor, or delivery? Did they have high risk pregnancies? So these are all different type of questions to ask when thinking about their reproductive history. And then physically, like, do they have physical and medical conditions that play a role? And then we have to, in all those aspects, also look at family history. Because like I mentioned earlier, those who have like family history of depression, anxiety, there's a risk factor for that person developing those symptomology, either throughout their adulthood or childhood into adulthood, or within the perinatal period. And then some psychological factors, mental and emotional history and health, personality factors such as perfectionism, like everything has to be perfect and be very rigid on those thought processes, or difficulty with like life transitions. So transitioning from let's say it's just two people, so the couple, and then transitioning from being pregnant to having a baby, transitions in lifestyle expectations can all play a role. Low self-esteem, self-confidence, and self-worth, unhealthy or abusive relationships, poor concentration, poor communication with their partners or really their support network, problems with safety within the home or them physically feeling safe. Sleep pattern is definitely a factor, as we talked about all the different perinatal mood anxiety disorder. All of them had sleep disturbance as one of the indicators. And then we have the psychological factors. So if there's experience of trauma, whether it be child abuse and neglect, intergenerational trauma, inter-partner violence, domestic violence, PTSD-related symptoms, loss and death, racism and discrimination, oppression, social change, such as like moving to a new area, not having friends that can relate to their experience and relate to them. I've often had clients who kind of like say like, I have friends, but they're not pregnant, or they don't have kids, or they have kids, but they just don't understand like how I'm feeling. And they say things like, oh, well, it'll get better soon. That's not very helpful for a person who's experiencing what they're experiencing. They have lack of support from partner, family, or the community, and they feel socially isolated, just like we talked about previously. Next slide. So there are other like high risk groups as we talk about the different factors. Please note that there are certain groups in the perinatal period who will have a higher risk of experiencing a PMAD due to social, economic, or health concerns. It is important that we keep these groups in mind as we provide care to them. While this is just only a short list, we need to also consider like being able to have universal screening to be able to assess and provide psychoeducation for perinatal mood and anxiety disorders. It also may be better with targeting education to clients and informing our clinical judgments. So some of the groups is those who go through adoption, breastfeeding, chest feeding, human milk feeding difficulty, low income, their employment status can play a role. Access to care could also play a role there. There are teen parents, unwanted and unplanned pregnancy. If they are a veteran or service member of a service member, or the family of that service member, whether it be the military spouse or dependents. Different racial groups, including but not limited to African American, Black people, Hispanic, Asian, Native Hawaiian, Alaska Native, and Indigenous people. Next slide. When we talk about risk factors, we also have to talk about protective factors that can help a person recover from a PMAD, because it essentially lessens the impact or even prevent PMADs. While many risk factors listed in the other slides are based on the client history, many protective factors are actionable things. For example, we can't change their past history of trauma, but we can increase their social support, their breastfeeding or human milk feeding support. We may help them build confidence and skills as a parent. So some protective factors include like a balanced nutrition, physical activity, or healthy sleep patterns, family planning support for unintended pregnancy, or just overall family planning support. perceive or intact social and maternal supports, parenting confidence, recognition of traditional postpartum cultural practices, which could actually be a protective factor, positive parenting role models, support of their breastfeeding or human milk feeding decision, or even if it's formula feeding decision, as well as healthy co-parent involvement. Okay, next slide. So let's go ahead and dive into some screening tools. We're kind of going to go through it fairly quickly because we have about 10 minutes left. Next slide. So the first scale is the Edinburgh Postnatal Depression Scale, which I mentioned earlier when I was talking about the statistics with bipolar disorder. An assessment that is mostly used by those who have contact with perinatal people. That includes OBs, midwives, mental health professionals, doulas, home visitors, etc. This assessment is really short. It's 10 questions. It's free. It's easy to score. It is validated for pregnancy and postpartum. It assesses for depression, anxiety, and harm to self. There are some problems with the assessment, like I was mentioning earlier, that it doesn't always assess for like hypomania and mania, or it doesn't necessarily assess the symptomology, all the identified symptomology for anxiety. Next slide. The next one is the Perinatal Anxiety Screening Scale, or also known as PASS. This assessment is often used to screen a broad range of anxiety symptoms during pregnancy and postpartum. It consists of 31 questions. It's easy to complete and score. It's also free. And is sensitive to how anxiety is presented in perinatal people and is often used in various settings. This assessment assessed for like acute anxiety, adjustment, general worries, and specific fears, perfectionism, control, trauma, as well as social anxiety. Next slide. And then last but not least, we have the Mood Disorder Questionnaire. This assessment is used to specifically screen for bipolar 1, 2, and bipolar NOS. It has 18 questions, easy to score, easy to use. It's also free. And when we talk about bipolar disorder and just identifying their symptomology, it's very important to have a very good initial evaluation, since people are often misdiagnosed with major depressive disorder when they're actually present with bipolar disorder. Screening clients in the perinatal period is an integral part of psychoeducation between the provider and client, and can actually empower clients and their support networks to understand their level of risk and navigate preventive measures, including those protective factors that we talked about earlier. Also, it's important to screen the partners, because the perinatal period is a time of change for everyone who's involved. Perinatal mood and anxiety disorder impacts the entire family unit, and about 10% of partners actually develop a PMAD when the birth person also exhibits PMADs. However, there are some occurrences, like if the birth person doesn't have a PMAD, but the partner may have. That's why screening for partners is an essential part of understanding how the entire family unit is coping with the time of change. Next slide. So we're just going to go really quickly about Postpartum Support Virginia services. I've already mentioned it earlier. So we do have supportive services such as a warm line that people can text or call. We have social support groups pretty much Monday through Saturday. We have daytime groups as well as evening groups. We also do have specialty groups for NICU, women of color, feeding, pregnancy after loss, military, and pregnancy. And we also have a peer mentor program, which essentially is a program for those mentors who experience a PMAD. They're giving back and supporting other people and walking along with them in their journey to healing and recovering. Next slide. There are some resources for not only just the family or the perinatal person, but also for mental health professionals. So we do have a support directory of a list of mental health professionals, psychiatrists, and other support services. that specifically are trained in perinatal mood and anxiety disorder or reproductive health. We do offer care coordination. So if you call our warm line and you need a help assisting with finding a support person, whether it be a therapist, psychiatrist, whatnot, for one of your clients, or your clients needs help, or other people need help with finding resources and support. We do offer handouts about perinatal mood and anxiety disorders, such as predictive risk factors. We have something called Path to Wellness that looks at different elements that can help a person recover and get better from PMADs, because PMADs is not forever. We have handouts on postpartum plans. So that plan essentially is to how to help them prepare for the postpartum period. Or let's say they're already in postpartum period. These are areas that they need additional support. There's also handouts on birth trauma and signs of anxiety. Next slide. Here are some other resources for those who are either in the perineal period or just needs access to services. Contacting the local health department, specifically when we talk about perinatal people, the WIC program may be helpful, family and social services, community service boards. There are some programs that have home-based supports. So for example, in the military sector, they do have home visitors that will come in their new parent support program to provide that support directly to a perinatal person and their family. There are a bunch of parenting groups out there, as well as lactation support groups. An example of one is La Leche League. They provide peer support for those who have breastfeeding challenges. If you have a client who is taking medication or is prescribed a certain medication and they didn't get information on how that medication impacts either their pregnancy or when they're lactating, you can use the resource from LacMed. It's a online database that looks at each drugs and the impact on lactation. Then the infant risk, you can actually call them because they are an organization that does a lot of research on different medication. But a person could call them and say, I'm taking Zoloft. What is the impact of Zoloft on baby? How much does it go into the breast milk? How much does baby ingest? If you have clients that are very anxious or questioning rather medication is the best choice for them. Next slide. If you're interested in learning more about PMADs, we do have mental health provider education courses. So the first is a PMADs basic provider training. It's more extensive than our training here, and we go in more depth in all the disorders. We have our advanced training that goes in depth on differential diagnosis, such as eating disorders that can impede in perinatal, the period, different treatment modalities that work for certain disorders, specifically those who in this perinatal period. We also do have education for healthcare providers to learn more of how appropriately screen patients and understand what's happening in their chart, but also have that impersonal conversation about PMADs. Next slide. Here's just my list of resources. Next slide. If you have any questions or comments about this presentation, please feel free to let me know. I'm actually going to put in the chat the link to the evaluation. So as I'm doing that, we have 2 minutes left, so are there any questions that you have about anything we discussed today?
I have a quick question because I do need the credits. So are you all going to send out a certificate via email, or how would that work?
So if you need MBCC credits, you will get an email directly from me. But if you need NASW CE, so social work CEs, just let us know so I can mark that and get next to your name. And then you will get an email directly from NASW. So
Yeah,
we'll need to know about that. in advance.
Yeah, because I'm an LPC and I know that we have to have 20 CEUs or you say CE classes
Yeah.
per year. So yeah, I definitely would need that as well. I did put that in my bio that you had us type.
Perfect. Thank you. Thank you for
Thank
asking.
you.
You should receive the CEs within a week from today.
Great. Thank
if
you.
it's for NBCC.
Yes, yes.
NASW, it may take maybe about a week to 2 weeks, just depending on their process on their end. Any other questions, comments? Did I put that in the chat? So I just put the evaluation form in the chat. Please, please, please fill out the evaluation. And that's all I have for you all. Thank you so much for listening in this presentation. Hopefully this has some impact on your work. And if you have questions or you want to learn more about perinatal mood anxiety disorders and how to provide appropriate treatment for this population, please feel free to reach out to me. I'm going to put my email in the chat as well.
Thank you so much. This was great.
Thank you.
Yes, thank you for being here. Have a good rest of your day, guys.
Thank you. Bye.
Bye. Thank you.